wrinkled and the lens is also endpoint type, nothing but endpoint. Ademotundi ripen avi dantlo the cortex is liquefied and just is milky fluid, and the yellow colored nucleus is settled down. Here the entire lens is shriveled and shrunken, and so then when the lens is shrunken, that means it leads to the decrease in the size of the lens, that leads to deep anterior chamber. So in the hypermature cataract, the sclerotic change, the anterior chamber depth is increased, whereas in the immature cataract, when the lens is swollen, that leads to decrease in the anterior chamber depth. Here, that is the increase in the anterior, deep anterior chamber. There, the immature cataract with the swollen lens. In the immature senile cataract, there is the shallow anterior chamber. That means anterior chamber changes are seen in case of the cataract, even though anterior chamber is not related to it, and no change is present in this. In the anterior chamber involvement is only because of the lens changes. It may be due to swollen or maybe shriveled lens. And so the sclerotic hypermature cataract, the deep anterior chamber is seen, and the wrinkled anterior capsule is seen, and the dense white capsular cataract in the pupillary area, as in the case of the Morgagnian cataract. And here another thing is tremulous iris. That means there is the iris is freely mobile because it is the lens is not having any support, and the what is that there is a gap between the lens and the cataract. That is the lens and the iris. So the tremulous iris is iris bombay, and iris is mobile, freely mobile. And the nuclear and the sclerotic cataract idiopathogenesis, intensification of the age-related changes associated with the high dehydration. Here, this is a dehydration. Nuclear or the sclerotic cataract means there is the dehydration and compaction of the nucleus. Whereas in the immature, that is a cortical cataract, it is the hydration changes. That means, I already told you, it is the derangement of the water metabolism and the protein metabolism. In the cortical cataract, what is happening is there is hydration of the cortex, whereas in the sclerotic cataract or the nuclear cataract, the dehydration and compaction of the nucleus. So what will happen there in the case of the cortical cataract? When it matures, it leads to the liquefaction of the cortex. Here, what will happen? The entire cortex becomes hardened. That is, the hard cataract is formed. So because of the compaction of the nucleus, significant increase in the water insoluble protein. Why it is happening like this? It's the water insoluble protein. And the lens becomes inelastic. Then what will happen when the lens is inelastic? The function of the another function, in addition to the visual function, the another function of the lens is the accommodation. So during accommodation, the anterior part of the lens will bulge and lead to the increase in the curvature. But when it is inelastic, what will happen? It cannot move. It change the anterior curve, that is the curve shape of the lens. Then it loses the power of the accommodation. Changes begin centrally and slowly spread to the periphery. But whereas in the cortical cataract, what happened? We have to see the periphery first. So we have to dilate the cortex, that is the pupil. So we have to see the lower nasal quadrant. First, I already told you, lower nasal peripheral quadrant, where the opacification starts. But in the case of the nuclear cataract, the changes are seen centrally. That's the one main point we have to think of is in the daytime, the patient is unable to see the world, that is the environment clearly, whereas in the dim light, he can see more clearly the daytime. And so the deposition and also deposition of the pigment gives characteristic color of the nucleus. How to differentiate the nuclear cataract and the cortical cataract? The cortical cataract is pearly white in color, whereas this is the brown color or black color or amber colored nucleus is seen in the sclerotic cataract. This is due to the deposition of the pigments. See, this is the color. Instead of the pearly gray color, it is like this. You see, this is the brunescence, that is the brown color. This is still darker, more pigment is deposited, so it is the nigra. And the rubra, it is a mixed, somewhat mixed cataract. And behind that, there is a shadow, clear, what is this? It is red colored like thing. And then complications. So what are the complications? The phacoanaphylactic nucleus, uveitis is, yes, even though it is cataract, it will involve the vascular coat of the eye, that is the uvea. That leads to uveitis. Inflammation of the uvea occurs in case of the senile cataract. Why? It is due to the anaphylactic reaction. Okay, why? Because the lens protein is totally covered with the capsule, so the body won't recognize the lens protein at all. Because of the damage, what will happen? The capsule is permeable to the lens protein, leading to the inflammation of the uvea, because it thinks that it is a foreign antigen. And then lens induced glaucoma. Already told you that is in the immature senile cataract. What will happen? The AC is shallow because of the increase in the size of the lens. And when another is the subluxation or dislocation of the lens, because this is the hypermature cataract. What will happen? Because of the lens, that is sclerotic cataract, the lens weight is more increased and it cannot withstand the increased weight. So the jonules will be weakened and leads to the subluxation or dislocation of the lens. Okay. Then another cataract is the complicated cataract. That is ocular inflammation and degenerative disorders and the nutrients or the metabolic defects leads to the lens opacity. That is that some of the causes are the another corneal ulcer and the glaucoma and any condition, all the conditions will lead to the cataract formation, including the retinal detachment, including the that means retina related problem like high myopia, the retina is involved, and whereas the intraocular tumors and retinitis pigmentosa and the glaucoma, the diseases which you are reading in your book related to the ophthalmology like uvea, glaucoma, and the corneal ulcer, and all the leads to the cataract, that is called as when it is associated with secondary, when the cataract is associated with secondary causes other than the lens, it is leads to the lens. Cataract occurs secondary to the other problems in the eye, that is called as the complicated cataract. And here there is the primary disease changes. It is see here this the pupil is blocked because of the exudate, which occurs as a result of the uveitis. So in addition to the primary changes, and when we remove it, the lens also cataractus. Suppose when there is uveitis, what will happen? The patient is complaining of the redness of the eye and also the pain, unable to see the light clearly, and that is the blepharospasm, and all the features are there in addition to the primary disease changes and the redness, and we see the cataract also. Then what we have to do, we have to remove the primary cause and then do the surgery after 3 months of the inflammation. With inflammation, you should not do any surgery, even though the lens is cataractus, we have to remove it. I think it is all over in the previous class. And then I already told you that is the complication, secondary glaucoma, retina. the treatment of the cataract. There are many kinds of medicines, but none have the positive effect. The surgery is the chief method which have to treat the cataract. And what are the symptoms? So the symptoms of related to the cataract are very slow. Mainly that is the decrease in the visual acuity, and also the contrast sensitivity is decreased, and the color sensitivity vision is also impaired. So the image is blurring of the image is progressing slowly to the visual failure. It may take the years also. And the second sight of usually some cases, the patient at one time unable to see clearly the objects, suddenly they may get vision again. That is due to the increasing the refractive error, that is the refractive index of the lens, because of the nuclear fibers compaction, leading to the sight gain, and the patient are able to see the vision, able to see the world clearly. That is called as the second sight. This is due to the increasing myopia. And the symptoms already told you, the double vision or the multiple images, and the starbursts around the light. That means the color shadows that is present in the around the lights. This also occurs in case of the glaucoma, and the color discrimination also decreases. Okay. Rarely, the swollen lens can cause the acute rise in the intraocular pressure, closing the anterior chamber. That is the angle closure glaucoma. I already told you this is the anterior. This is due to the shallowing of swollen lens, leading to the formation of the decrease the shallow AC. And whenever the eye, it is more common in the case of the hypermetropic and the small eyes. What will happen? The outflow of the aqueous is not possible because of the peripheral anterior, that is AC angle closure. So what will happen? Sudden pain occurs in this patient, and episcleral veins also congested like this. That is leading to the intense pain in the eye. That is nothing but due to the formation lens-induced glaucoma, and leading to the inflammation also, because the lens leaking lens capsule leading to the closure of the pores of the trabecular meshwork. So there is inflammation of the, in addition to the closure of the pores of the trabecular meshwork, the inflammation of the trabecular meshwork also occurs. So leading to the immune reaction, leading to the, this is all due to the leaking proteins only. And so that is the trabecular meshwork inflammation and swelling, and that is the closure of the trabecular pores by the lens protein will lead to rise in the intraocular pressure. Okay, so leading to the secondary glaucoma. Lens, that is nothing but lens-induced glaucoma. Sudden onset of the pain and redness and rapid change in the vision. Rapid change in the vision occurs due to the edema of the cornea. Okay, and here you see that is the lens is dislocated and it is displaced down. And this is the pigment which is present due to the formation of the synechia because of the shallow AC. The contact between the lens and the swollen lens and also the iris and the inflamed iris lead to the formation of the iris pigment deposition on the lens and the synechia formation and the cataract surgery. Then what we have to do, the only treatment of the choice is the removal of the cataract lens. So what we have to do, we should not do without investigating a person. As for any case, as in the case of even though it is the major surgery or the minor surgery like the eye surgery, we have to thoroughly investigate the patient. So what we have to do, the pre-operative ophthalmic evaluation. Okay. Evaluation should be done. That is the comprehensive evaluation by the operative surgeon should be done. That is, first we have to do the A scan biometry for the intraocular lens calculation. And what is the power of the lens? We have to implant after the cataract surgery. We have to calculate first by doing the A scan biometry, and then we have to do the other tests also, like contrast sensitivity, but they are not routinely, we are not doing. If it is available, we can do the contrast sensitivity, glare testing, potential acuity, and the specular microscopy, the corneal topography, and the B-scan ultrasonography. But we are doing B-scan ultrasonography regularly in the case of the hypermature cataract. If in the higher hospitals, like so many hospitals are there, like the Aravind hospitals and all this, contrast sensitivity, glare sensitivity, and we can do these tests. But the B-scan ultrasonography nowadays is mandatory. Yes, especially in the case of the mature senile cataract, because there is we cannot see the condition of the retina inside and the optic nerve. So we have to do the B-scan ultrasonography, whether there is any pathology, like how is the vitreous and how is the condition of the retina, whether there is any retinal detachment is there, like whether to anticipate the vision of the person, we have to do the B-scan ultrasonography. And then send the patient to the physician, especially to know the condition of the heart as well as the lungs, to exclude any myocardial infarctions or any unstable angina. And to, as a routine, we have to know the general condition of the patient. We have to send it is better to send the patient, that is the before cataract surgery, to the physician. And we have to control the diabetes and also the hypertension beforehand. Otherwise, if there is a diabetes is not controlled, infection chances are high. When the hypertension, there is an expulsive hemorrhages like the choroidal hemorrhage and all the conditions may occur. And bleeding also occurs in while doing the case. So that may lead to the hyphema formation after the cataract surgery. And the routine medical testing like the blood test and EKG should be done. And it's do not increase, but even though it do not increase the safety of the surgery, we have to do it for our purpose. And the operating ophthalmologist explain the patient the symptoms of the cataract and what are the risks and what are the benefits and what are the alternative treatments. We have to discuss with this in this scenario to the patient beforehand only, and advise them to stop smoking. And also, why whenever there is a cough and expels, sometimes what will happen? The when we operate on that, this shallow ASI may occur because of the leaking of the intraocular fluid, that is the aqueous humor, and the refraction and the prescribing the glasses when appropriate. First, when we have to ask the refractionist to do the refraction and also the glass prescription, whether they are improving with the glasses. If they are improving with the glasses, we need not do the surgery at the earliest, and then we can prescribe the glasses. And the cataract associated with the visual loss that negatively affects the quality of the life by limiting the ability to drive safely, read, participate, the sports, etc. And in which cases we have to advise the cataract at the earliest period is whenever the patient complains that I cannot drive my car, and because there is a glare while driving the car in the nights, and also I cannot read, and I want to play in the, I'm an athlete, I want to participate in the sports. It is very difficult to see the distant vision because of the lack of the accommodation. Please, when the patient asks for the surgery, we have to do it. And also, whenever there is sudden secondary glaucoma, that is the lens-induced uveitis, we have to treat it, and then you have to do the surgery after 3 weeks. And then cataract inhibits the optimal management of the posterior segment disease, such as the diabetic retinopathy. Why? When there is a diabetic retinopathy, there is inhibits the management of the posterior segment disease is somewhat difficult because we are unable to see the posterior, that is the retinal changes. When we remove the cataractous lens only, we can clearly see whether it is the PD or the NPD or proliferative diabetic retinopathy or diabetic retinopathy, whether there is a macular edema, we have to see, and accordingly we will manage we'll give the treatment. So we have to do the cataract surgery in cases when there is the diabetes, to see the diabetic retinopathy, to exclude any problems related to the posterior segment. Okay. And then the patient, when the cataract surgery is contraindicated, the first and foremost important thing, when the patient is not willing to undergo, that is the cataract surgery, then we should not do on them. And then glasses and the visual aids provide vision that meets the patients at the earliest. So when there is improvement with the glasses, then we need not do the cataract at that time. We have to wait for few days and few months. And then surgery will not improve the visual function. Suppose when there is the macular scarring and the vision is the macular, that is the retinal detachment. In such cases, the vision it is not improved. What is the use in doing the cataract surgery? But the only one thing, whenever there is a pain and the patient wants the cat for the cosmetic purpose, then only we have to do with the consent of the patient only. And the patient quality of the life is not compromised, then we need not do the cataract surgery. And at the earliest, the immature cataracts and in such cases, we need not do, even though there are cataract changes. And the patient cannot safely undergo the surgery, as in case of the when the patient is diabetic, and also there is anginal attacks out there, when there is any associated diseases, when the surgeon thinks it is unsafe to do in such cases, we should not do the surgery. And then informed consent cannot be obtained from the patient and the surrogate. And the consent is also, in the doctor's point of view, is very important. When they don't want to give the consent, then we should not do. This is all the practical things we have to learn for your purpose. And appropriate postoperative care cannot be arranged in such cases. The postoperative care is very important. So in such cases also, we should not do cataract surgery and the surgical techniques. Then what we have to do first? When we are planning for the cataract surgery, we have to rule out any infection. And also we have to give some prophylaxis further to eradicate any subclinical infections also, like 5% povidone in the conjunctival sac prior to the surgery, and the topical broad spectrum antibiotic prior to the surgery also given. Even though there is no infection, there may be the subclinical infection also. So the broad spectrum antibiotic you have to give, and also the povidone into the conjunctival sac, that 5% povidone iodine, and the extracapsular cataract extraction or the phacoemulsification. There are the SSCS and also the phacoemulsification are the two methods we know nowadays we are doing. Even though the laser extraction is also there, but here what we are doing with the phacoemulsification and the SSCS, the two methods we are commonly using. The phacoemulsification is the preferred method. And the standard extracapsular technique may be required in extremely hot cataracts, even though the patient wants the phacoemulsification for the safety of the operation, and we have to do the preferred, that is the SSCOs in the case of the hot cataract. And then cataractous lens removal is intracapsular. There are two types, maybe the intracapsular and extracapsular. And this is the intracapsular means along when the lens, that is the cataractous lens, is still in the capsule, we remove that cataractous lens. That is the intracapsular cataract extraction. When that is extracapsular cataract extraction means we are removing the cataract out of the capsular bag. So that is extracapsular cataract extraction. Here what we are doing, the nucleus delivery is done, or otherwise the nucleus totally we can remove it, as in the case of the SSCS, or by the means of the phacoemulsification. Also, we are removing the cataract lens. Total emulsification by the sound waves. And then cataract surgical technique, what are the successful procedure? That is the capsule. First, we have to do the capsular fixation of the posterior chamber IOL. That is, what we have to do while doing, what would the things we have to consider? It should be there should be no trauma to the corneal endothelium. Otherwise, because it is usually occurs in the older age groups, so what will happen? There is the corneal decompensation because of the decreased number of the endothelium. Once the endothelium is lost, it won't regenerate. So we have to take care of that endotheliums. And so there should not be any trauma to the corneal endothelium, and also iris, as in the case of the iris dialysis, which will occur in cases of the heart cataract, and also we should not damage the intraocular tissues also, like the forehead and the iris and all the things. And then the incision design should be perfect, that it minimal this is the surgically induced astigmatism. So the incision in the SICS is only less than 6 millimeters, should be less than 6 millimeters to avoid the astigmatism. And even though, what is the problem associated with the astigmatism? We never get a clear image in the case of the astigmatism, so that we have to minimize the surgically induced astigmatism. All the care should be taken, and usually we have to give the incision 2 millimeters away from the limbus, and also it should not be too large, and also it should not be ragged, and also whenever we have to apply the sutures, it should be properly applied. It is not too tight or too loose. If it is loose, it will happen, that is the leaking of the intraocular fluid, that is the aqueous humor, and the infection chances are more. When it's too tight, it leads to the astigmatism. So the watertight closure of the incision or the self-sealing incision should be given to the patient, otherwise it should be sutured. Okay. Steps of the phacoemulsification. In the case of the SSCS, this is the limbus. We have to give an incision 1 and 2 millimeters away from the limbus, and about the 6 millimeters curvilinear, that is at the frown incision should be given, and the inner and into the corneal layers we have to go up to 1.5 millimeters, and then we have to separate when and then enter into the AC. I think that I. Oh, 1 minute. Just 5 minutes, huh? Okay. And then it is self-sealing incision, whereas in the SSCS is 6 millimeters, but in the case of the phacoemulsification, it is only 1 to 3 millimeters. And then the paracentesis incisions are there. We have to give 2 incisions here, and another one is here for the to irrigate the and to AC maintenance is for the AC maintenance also. And the staining of the anterior capsule should be done with the methyl blue, and also then we have to do the capsular rhexis. SACOs, usually what you see in our hospital is can-opener technique, but here it is what you are doing, that is the curvilinear incision is given in the anterior capsule of the lens. So there is the bag is there, clear bag is there, and so that we can implant, that is the IOL, into the capsular bag, so there is no tilting of the lens, so there are astigmatic changes are less in that cases. Okay, then after capsulorhexis, we have to do the hydrodissection. That means the separation of the nucleus from the cortex by means of the water jet. And then what will happen? The lens cortex is separated from the nucleus. Then the loosened nucleus, and by means of that is ultrasound are chopped and liquefied and then aspirated like this. This is the Phaco probe. And then complete removal of the epinucleus should be done. Otherwise, there is the chances of IOP rise leading to the secondary glaucoma after the cataract surgery. Then, after the complete removal of the epinucleus and the cortex, what we have to do is then implant the IOL like this. Okay. Then what are the complications? We will discuss in the next class. Already medicine madam came. కొంచెం అన్నట్టుంది స్లైడ్స్ ఉన్నాయి చెప్పేస్తాను ఏంటన్నారు అయిపోద్దా ఓకే ఓకే ఇది చూడండి ఇది చేస్తాను లేదు నెక్స్ట్ అది ప్రాబ్లం ఏమైందంటే వాళ్ళకి ఆడదు మధ్యలో డిస్కనెక్ట్ అది మ్యూట్ అయింది అందుకని నాకు 20 minutes వేస్ట్ అయింది Madam has given me the permission, so I am completing it. And then cataract surgery, what are the complications associated with the cataract surgery? During surgery, the nucleus may be dropped. And it is the 1% incidence is 1%. And there may be the chances of infection when we do not take any precautions to, already told you that iodine should be instilled and also the broad spectrum antibiotic should be given to alleviate any the subclinical infection. Otherwise, there are the chances of the infectious endophthalmitis, which is about 0.13%. And the range is 0.0 to 0.170%. And expulsive choroidal hemorrhage may occur whenever there is sudden gush of the aqueous comes out of the eye. What will happen? The choroid is separated from that, and so the choroidal hemorrhage, expulsive hemorrhage occurs. Then cystoid macular edema, and is most common in the case of the diabetics. It is around 1.4%. And there are also the retinal detachment chances are also there. We have to do very carefully and very slowly while introducing that cystome into the lens eye. And whereas the corneal edema occurs in cases about 0.3%. Why? Because of the increase in the IOP. And the dislocated IOL also occurs. And whenever there is a posterior capsule rent occurs without knowledge, when we implant the IOL, after when we dilate the pupil, what will happen? Because there is no support, so the IOL may be dislocated. It may be so that the dislocated IOL may occur. And in such cases, the patient may complain of the polyopia and or the diplopia. And then posterior capsule opacification, which occurs, is a very common condition. That is the 19.7% of the cases, because we are leaving the capsular bag, the equator part, that is still having the epithelial actively dividing epithelium, lens epithelium, that may progress back and leading to the opacification. Okay. Okay. Then we will discuss in the next class in the Saturday. Okay.
Thank you.
Class.